Welcome to the South Florida Vascular Associates Health Talk on Fibroids and what you need to know. My name is Vivian King, and I will be your moderator for today. The South Florida Vascular Associates are here to serve you in the best way possible. So take a listen.
I had multiple fibroids. I could look like I was like 6 months pregnant.
It just got worse and worse. And I was anemic. I had severe pain, very, very heavy periods. Sometimes I didn't leave my house because I was afraid that, I might, have an accident in public. It was a very difficult time. So after so many doctors, I was referred by one of the doctors to try here to see if maybe they could assist me.
You had really large fibroids in
Yes,
your
I did.
uterus that were pushing on different areas. Additionally, if these are causing symptoms, a gynecologist will recommend a hysterectomy, which is done in the hospital under general anesthesia. It has about a month recovery. There's another procedure, a revolutionary procedure called uterine artery embolization that we perform here at South Florida Vascular Associates on an outpatient basis that keeps you out of the hospital. And we inject these tiny little particles that plug up the arteries, and it will starve the uterus of blood flow and it kills the fibroid tumors. It allows you to keep your uterus. A lot of women don't want to have major surgery and lose their uterus.
The procedure was very easy. They led me through step by step. It wasn't scary at all. It was very comfortable. And the staff was very, very, very helpful and nice.
Well, I told everyone that my experience here was great. They took care of me. It's like a state-of-the-art facility. I came in early in the morning. They prepped me. I got everything done. And I just enjoyed the experience. And that's, it's hard to find sometimes, a place where, you feel like, they care. Generally, they care. Ever since I had the fibro procedure, I'm no longer anemic. I no longer suffer with the premenstrual syndrome, and my cycle is very, very light.
I've noticed that my stomach has gone down tremendously. I really feel good.
Why would you go to the hospital and have major surgery, a hysterectomy under general anesthesia that has about a month recovery, when you could come to South Florida Vascular Associates and have a minimally invasive procedure done without cutting here in the office and go home and recover in your own home?
So, we are gathered here today to talk about fibroids, the symptoms, and most importantly, what are your non surgical options for relief? So, a quick question before we get started. Ladies, if you would, will you take a moment and enter your age by answering the poll that should appear on your screen? We'll give you a few seconds to do that. And if we can have the results of the poll. So thank you so much. We have about half of you who are in the age between 40 to 49. And then we have lesser in between. We have some people in our 20s, some women in our 30s, and some women like me over 50. So thank you so much for taking that poll. It really gives us a chance to see who we're talking to today. And I think we all need to hear this message. So remember though, throughout today, if you have questions during the talk, please just submit them in the Q&A on your screen. We will present questions to Dr. Julian at the end of the session. But you saw that video and you saw someone in there, Melissa Felix. And Melissa is with us today. She is our patient advocate. So at this time, I would like Melissa to join us. Hello, Melissa. You look beautiful and on the beach, no doubt. I love that. And if you can unmute yourself, I'm going to ask you a few questions.
Sure. Good morning. How are you?
I'm great. So you kind of said it in the video, but what was your life like with fibroids?
So I think in 2015, I had gotten, I was sick, not anything related to the fibroids because I didn't know, and I ended up hospitalized for about 3 days. And so during the hospitalization, I ended up having to have an endoscopy, both an endoscopy and a colonoscopy, because they thought perhaps there was something, some other issues going on. And so it was after I had the endoscopy that, when I woke up, the doctor was telling me, she said, you are, you have lots of fibroids. I mean, in essence, she just basically said your whole uterine cavity is filled to the brim with them. So much so that your uterus is tilted, your cervix. And so, I had heard about fibroids. It runs in my family. My mom had a hysterectomy my last year in high school. However, because it was happening to me, I just wasn't on top of what it would, what that would look like, or if, I was in, maybe in line to experience some of those things. So that's when the journey started in 2015. So, after I was released from the hospital, I had a lot of follow-up appointments to do and things of that nature. And so in those follow-up appointments, that's when they were saying like, you have these issues. And so they referred me to, to go see my gynecologist, which I did. He referred me to another doctor who then referred me to another doctor and then back again to my gynecologist because I was having a lot of heavy bleeding. I mean, to the point where, at the time I worked 10 minutes away from my house. I would get ready in the morning, put my clothes on. And by the time I got to work, I would have to change. I already had, it was through, and I'm wearing like, I'm wearing an Ultra Plus. It's a very large tampon, but I was bleeding heavily. I was anemic. I had to take iron pills twice a day. Because I was so anemic, it was pushing on other organs. There was all sorts of things going on with me, and I didn't understand it at the time. And so it was just a very difficult time for me. I was tired all the time. I didn't feel well. My stomach was very big. It did look like I was pregnant, like 6 months pregnant, and people would ask, are you having another baby? And, that question is sometimes, it can be embarrassing, especially when, it's children, they're rubbing your stomach. Oh, you're having a baby, but that's not what it is. And so the very last doctor that I saw, she also said, well, because of your age, you have one son. My son was 17 at the time. She said, oh, you're not going to have any more kids. You can just have a hysterectomy. And that wasn't the answer for me. And I cried. I did. I cried because it seemed so final. But my mom said, and my mom is a nurse, she's a retired nurse, and she told me, she said, that is not an option for you. She said, you need to find something else. She said, look it up, research it, do something. She said, but you need to go back and you need to tell her that's not what you want. And so I went to see her again for a follow-up, and that's when she gave me the pamphlet. And she said, well, if you don't want to do this, she said, check this out. She said, I've heard people say, it works well for them. She said, I can't say, if you're eligible or not, but go see them. And so that's what I did. And it just took off from there.
So Melissa, you're saying that pamphlet, did it have information about the UFE procedure?
It was a pamphlet. It was a pamphlet from South Florida Vascular Centers. I had never heard of it, and so it was a pamphlet from there, and it talked about the different procedures that they do, but it also talked about the UFE, and so it gave information. She gave me a whole bunch of information on it, but she told me, contact them, make an appointment, and see what they can do for you. So immediately, I made the appointment. I got in. I think maybe that same week. I didn't wait long. I went in. I had all of these medical records, and so they sent me to do a full body MRI. I had to do it with contrast and then without contrast. And so I had to wait for that to come back. And upon that, Dr. Julian contacted me when he was reviewing those records, and he was like, wow, he was asking me questions like, are you experiencing this? And I'm saying no. And he said, if you told me yes, then I could totally understand because of the way that some of the fibroids were positioned and were growing. I had a really large one, like at the very top of my stomach, like it was taking up so much of my blood function, he said, so he could see how I was so anemic. And so upon, him looking, he said, we most definitely can help you. We'll schedule the surgery right away, which they did. In a month, I was scheduled, and I was so elated to get some relief.
And it's important to notice it's not a surgery. So it's a procedure. And
It's a
so I
procedure.
want
Mhm.
the women who are listening to understand that. So how was your experience going through the procedure?
So they gave me, like, you have a bunch of prescriptions that you have to fill and then bring in on the day of your procedure. That was easy. I did what I needed to do. My mom took me the morning of. They prepped me. They told me, what would be going on. They told me, the things that, what they were going to do, what they were going to be doing, and that I would recover, probably for a few hours before, they released me to go home. And so I remember being wheeled in, they were saying some things to me, but then the medicine kicked in, and then that's all that I really remember until I woke up. But it was very painless. I didn't feel any anxiety, or, I wasn't worried about, what, being in a hospital setting. It was more small, it was intimate. So it felt, kind of like you were kind of, like in a boutique, I guess, like, like those boutique services. And so that's what my experience was. I woke up, the nurses were so nice. They brought my mom back once I woke up, just so that I could see her, she could see me. I was out of it. I was heavily medicated. And then, after, I guess my science vital, after everything was done, I left at the end of the day, and I went home, where I recovered for about 2 weeks. I took 2 weeks off because of the type of job that I was doing at the time. But after the first week, the first night was the hardest. They did tell me that first night is the most painful. And it was, but my mom stayed with me. So she's kind of like my nurse. But after the first day, by the second day, every day I felt better and better. It wasn't at all like, having like major surgery. It was a quick turnaround time. I just had to be very careful, but it was much easier, I believe, than having the full surgery, the experience. You can't walk, you can't. People have to do things for you. The first day I was by myself, and the second day people came to the house, but I was able to move around. I could do things that I needed to do for me. I wasn't bedridden in that way. And after the first week, I felt pretty good. I really did.
So what is your life like now living fibroid free?
Oh my gosh. So like now, before I had my the procedure done, I would have horrible cramps. Like it felt like I was in labor. Sometimes up to a week before I even got my cycle. And so now I have nothing. I have no cramps. I don't swell up. I used to swell up too before that. My cycle is very, very light, to the point where I just wear a panty liner. I mean, a very light panty liner. Like that's just how scant it is. Sometimes I forget that I have. Sometimes I forget that I have it, because it's a totally different. I don't even know the word to say, but it's a totally different cycle than I had, and I dealt with that for quite some time, because I just thought, oh, I'm getting older. I was approaching 40, and I've read things that said, as you get older, your cycle begins to do, funny things. But I had no idea that mine was related to the fibroids. And so now I can do what I need to do. I don't have to buy my pants bigger so that I can fit my stomach in it. I can wear a size 10. That is my size. I don't have to buy a 12 or a 14 to accommodate my swollen belly. My feet aren't swollen. I'm no longer anemic. I don't take iron pills anymore. There was a whole slew of health issues that I had no clue were related to my fibroid issues. And I think last year I had to get a pelvic ultrasound done. My doctor ordered that. And in previous pelvic ultrasounds, they were never able to see my ovaries, neither ovary, my left or my right. But when I went to go do this, she told me, she said, oh, I can see. She said, I see both ovaries. And so that for me was a win-win, because I remember when they couldn't see anything. It was just full.
Right.
Full of fibroids, and now that's not the case. And I think this has been maybe it's going to be 3 years, I believe, this month. And so I feel good. You see my beach background. I'm on my way to brunch. And so I live well. I don't have any of those issues, and I feel good. I'm
It's,
glad that I made the choice.
I'm glad you did too, because it sounds like you had a huge turnaround. So what advice
Huge.
do you have for women looking to treat their fibroids, the women on this call and on this Zoom?
The advice that I would give to any woman who is suffering or is looking for some relief with regards to their fibroids, I would say, make sure that you do your due diligence. You research, you check things out, make sure that you make the choice that's best for your life, for your body, and just best overall. And that's what I will tell anyone, because had I made that decision, it was such a permanent decision. And at the time I was unmarried. I'm still unmarried. However, I felt like if I were to get married and I met someone and I married him and, he said, look, I want to have a child, I wanted to have the option to be able to do that. And so, as a woman from one woman to the next, I will just always implore that you make the best decision for your body, for your life, and what best fits you. I can't say that your experience will be like mine because, everyone is different. Everyone is, unique. And so my experience may not be yours. However, if it's something that, something that would alter maybe what they're saying to you, what they're telling you, I would say you fight. You be your own advocate. Be your own advocate. Advocate for yourself. I know that doctors, we trust our doctors. They're trained to do what they're doing and to tell you their opinion, but ultimately that's just what it is, their opinion. You know yourself, you know your body, and you know what you want long term. And so that would just be my advice, is that make sure that you advocate for yourself, you research, you get second, third, fourth, fifth, if it takes 10 opinions until you feel like this is something that you want, you do that, and don't stop, and don't let anyone stop you or tell you that this won't work, or oh, you shouldn't do that. Follow your heart, follow your mind, and always choose you first.
Melissa Felix, thank you so much for sharing your story and your journey. I'm sure there are some of the women on this chat and this Zoom that can relate to those symptoms that you were talking about. By being here today, all of you are on the road to recovery. As Melissa said, she turned her life around. This procedure turned her life around. So thank you again, Melissa.
You're welcome. Thank you. Thank you for having me.
So ladies, now the moment you've been waiting for. Let me tell you about Dr. Julian. Dr. William Julian is the president of South Florida Vascular Associates, a nationally recognized vascular and interventional physician practicing in Florida. He specializes in vascular and endovascular techniques, treating most of his patients at his office in the country's first of its kind endovascular surgery suite. Dr. Julian received his medical degree from the Washington University School of Medicine in St. Louis, Missouri, and completed his residency in diagnostic radiology at the University of Minnesota Hospital in Minneapolis. He is fellowship trained in interventional radiology from Miami Cardiac and Vascular Institute and board certified in interventional radiology. Dr. Julian is an active member of multiple professional societies. He is a co-founder and past president of the Outpatient Endovascular and Interventional Society, and just this past month, named a distinguished fellow of the society. He is a nationally recognized speaker and physician educator in advanced and cutting-edge minimally invasive procedure. And of course, you are about to hear from this dynamic physician. Dr. Julian, thank you so much, of course, for joining us today.
Good morning, Vivian. Thanks for having me, and welcome to people from around the country and who are sharing their morning with us. It's nice to have everyone. And I really want to put a shout out to Melissa, our patient advocate, who could be doing other things with her new fibroid-free life, but decided to join us this morning and tell about her experience. And it was a delight to see how how good she's done. And hopefully we can help some other ladies out there.
And might I add that you are looking mighty spiffy in that nice cap.
Well, thank you. It's
So
my COVID look is the beard. I'll shave it off when the COVID is gone and go back to my older look.
Well, thank you so much. So let's kind of dig right in. Talk about what uterine fibroids are.
So uterine fibroids are benign tumors of the uterus. Think of them like a round ball of muscle. It's like a hard rubber ball. Most women have multiple fibroids, not just one, and they occur during childbearing years because they are fed by the estrogen and progesterone that the ovaries make. And so when you reach puberty, you can start to form these. And when you reach menopause, they involute or shrink up. And so you don't really hear about fibroids in women in their 60s, 70s, and 80s because it was that childbearing years that they were really symptomatic. It's very common. Probably about 30 to 50% of women who are 35 have them already, and they continue to grow. And so by the time they're 50, 60 to 80% of women have them. All women can get them, but it's much more common in Black women and Latina women. Black women get it probably 3 times more than white women. It's not really known why. Some people think it's genetic. The question comes up, why do Black women get it more frequently? And there's a lot of theories. Most of them I don't know if I can believe, but it's never been proven. But you'll hear things like vitamin D deficiency, obesity, abuse at home, of all things. And I don't know how all these factors in. There's even a theory about hair relaxer and the chemicals and the hormones in it can actually absorb and somehow feed the fibroids. So I don't know if any of those are true, but the genetic one to me is the most believable one. The data on the other reasons isn't as common, but whatever the reason, it's extremely common, and women have a lot of symptoms. And it's you know, when 80% of the women have it by the time they're 50, then you know that that's something that we need to know how to deal with, and hopefully in a minimally invasive way.
Right. So you spoke about the symptoms, and so did Melissa speak about her symptoms. What are some of the symptoms that you see, not only in Melissa, but even other women?
So I'm going to show you a couple of slides, which I think will help people understand the wide variety of symptoms that can occur. So let me see if I can figure this out. Okay, so can you see my cartoon here?
Yes, we
Okay,
can start.
so on the left side, we have a cutout of you see the normal size uterus. Here's the vagina, the uterus with the endometrial canal. This is where the tissue is that you'll slough during menstrual periods, and this is where the baby develops. Here's your ovary with the fallopian tube, which is a little channel that the egg would come down on. And this is kind of a normal size uterus here, but this muscle in the wall of the uterus is where the tumors form, the fibroids, and they can occur all different parts. So the most common are these ones in the middle of the muscle. They're just called intramural. If you have them on the inner lining here, those are the ones that can cause bleeding, that you hear a lot about bleeding. Now, the ones more on the outside, they're not going to cause bleeding, but these can grow quite large. They can look like, you know, golf balls, plum-sized, oranges, even like grapefruit size, and you can have multiple ones. And these, when they grow like this, they can compress on different areas in your pelvis. And I looked at some of the cases that I had been seeing the last few weeks, and I pulled some pictures. I don't mean to make you a diagnostic radiologist here, but these are actual cases that we've seen lately. These are MRIs. The ones here where you see the hip bones are, you're looking directly at a woman, and this is slices. Here's the bladder, here's the uterus. If you look at these two side ones, here you can see the spine, the butt. This is the bladder. If you look over here, you see vagina, uterine canal. And what I want to show you here is, notice this black area. That is a fibroid. All these little black guys are fibroids. And this one is bulging on the uterine canal, so that can cause bleeding. It can slough off. Here's another one in the front. It can cause bleeding. But if you look at some of the other areas, you can see it's pushing instead of filling the whole pelvic inlet here. And so this unfortunate lady, but fortunate because we could fix her, but she has problems with constipation. You can see that the colon, which has to slide underneath the backside between the spine and the uterus, is a little scrunched in here. So she has constipation. This is not an impressive case of the bladder being compressed. This is the bladder filled with urine. But she does have frequency of urination, meaning she has to urinate a lot. And I'll show you some pictures where it's actually compressed quite a bit more, and has a feeling of fullness. You can see this is enlarged like maybe 3 times normal. And so she'll have those symptoms. Here's another lady who has this is the endometrial canal. There's a couple small fibroids, but she has one really large fibroid on the right side that's compressing the bladder. You can see on the side view here that the bladder is, probably half the size normal. And so this is someone like Melissa. This is not Melissa's, but by the time they get to work 20 minutes away, is about ready to visit the restroom again, and every 30 minutes throughout the day. So also, the uterus is being pushed back. So this poor lady had back pain. Here's another one. If you look on the side here, there's an even larger fibroid tumor, along with some smaller ones next to it. And this lady had a myomectomy 3 years ago. So that's when the surgeon will actually remove through surgery the individual fibroids. And you're probably asking, well, how in the world did this grow so fast? And that we'll talk about that later, but that's actually fairly common after a myomectomy. But this woman does not have much room for her bladder to fill, so she has frequent urination, and has trouble at her gym performing a lot of the exercises she used to perform, has back pain and bloating. Here's someone who's got a massively enlarged uterus. So the uterus should be right around here. And you can see this is a lump, this is a lump, this is a lump, this one, huge one coming off, sticking out to the side here. And you can see these here. So this is pushing on all sorts of things. Here's another one with a whole bunch of lumps. So basically, if they're in the inner lining, it can cause bleeding. If it's on the outside, it's whatever it's pushing on, the bladder being most frequent. Some women have painful intercourse, bloating, back pain, sciatica, where the pain shoots down the leg because you have a nerve that's being compressed. It's really quite impressive how you see how big these are. This was a healthcare worker, and when we were doing her laboratory tests, her hemoglobin we saw came back at 5.4. Normal hemoglobin is about 13, 14, or 15, and people are almost passing out when it's below 6. So she was actually getting short of breath going up and down the stairs, and she had to get a blood transfusion. And fortunately now we've had a chance to treat her. So hopefully that'll get a lot better. She had painful intercourse as one of her symptoms. So that is the types of symptoms, which you can see are based totally on wherever the fibroids are and how big they are.
Mm-hmm. So those were MRI pictures, right?
That's correct.
And so, but you don't necessarily need an MRI to diagnose fibroids. Because I had fibroids, and actually my gynecologist found them, when I went for my regular Pap exam. And
right.
So how do you diagnose uterine fibroids?
So they're generally first picked up on physical exam by your gynecologist. They'll either feel lumps on your belly, or when they do their pelvic exam, or they might look because you're having bleeding, and they'll start with an ultrasound. An ultrasound is an excellent way to screen either transabdominal, where the probe is on the outside, or transvaginal, where the probe goes into your vagina and gets you closer to the uterus. That'll show you the fibroids. And a lot of times that's what the gynecologist will use prior to a hysterectomy or a myomectomy, where the tumors are removed. But when we are doing our embolization, we like to get an MRI before, because we want to see where all the fibroids are, be able to measure them so we can see how much they shrink. And we also importantly want to make sure that they look like a typical benign fibroid tumor and not the super duper rare cancer. We also want to make sure there's nothing wrong in the adnexa, where the ovaries are. Make sure there's nothing confounding the situation. Like if someone had an ovarian tumor causing some pain, you wouldn't want to do an embolization to treat a fibroid tumor, which they could also have, you'd have to go after the tumor. So the MRI is a much more elegant, sophisticated, it's somewhat, costs more. It's a more modern imaging modality, but it's not the first thing you're going to do.
Right. And so how are uterine fibroids treated? Like I had fibroids and I ended up having a myomectomy. Unfortunately, the fibroids didn't come back like that one picture that you showed. So how are uterine fibroids treated?
So I'm going to show you a slide that will show you the general categories. So the first thing a gynecologist might do is try some hormonal therapy. It generally will temporarily help, but there are side effects of the hormonal therapy, and as soon as you stop, they come back immediately. So it's a good Band-Aid, but it's not a long-term solution generally. The typical traditional surgical options are a hysterectomy, which is where the surgeon removes the entire uterus, often with the ovaries and the fallopian tubes. It can be done through an abdominal incision, which is major surgery. If the uterus is small enough, it might be able to be done what's called transvaginally, but a lot of times that can't be done because the fibroids are too big to do that way. And there's newer techniques with laparoscopy where you put a scope in, but once again, the bigger fibroids are hard to get through a tiny hole. And so some people may end up with a big incision. You had what's called the myomectomy. A myomectomy is simply the name of the word to remove the individual fibroid tumors, those rubber balls, basically. And those can be done through a major incision, and it can be done through a laparoscope. But the bigger the fibroid, the harder they are to get through, and the more likely you're going to have an incision. If I could just talk a moment about myomectomy. Myomectomy is good if you have one or two and you want to get pregnant. If you remove those one or two and you time your pregnancy, it'll work. But the problem is most women have dozens of fibroids, and it's really impossible to see all of them and to and if you can't, let's say you have 10 big ones, you can really distort the uterus and scar it so that it'll be hard to get pregnant. And the more extensive the fibroid surgery, the more likely you are not to be able to get pregnant. And leaving those little ones, which is almost impossible not to do, those are the ones that recur. Remember, I told you that the estrogen and progesterone are driving the fibroids. It's feeding it. It's like watering the oak tree. And if you remove several big fibroids, the hormones are now able to feed the little ones. And so it's not uncommon that if in 6 months, they grow like an oak tree, a little oak tree becomes a big oak tree, and you'll do an ultrasound and think almost like they had no myomectomy because they all came back. So the myomectomy has some issues, and it's very common they recur. I have endometrial ablation here. That's only really good if you're having bleeding, and it basically kills the inner lining of the uterus. Now, the hysterectomy and the myomectomy have a much longer recovery than, say, uterine embolization, which I'm going to talk about, and they're done in the hospital under general anesthesia. Of course, people are trying to avoid the hospital these days. I think they always were, but even particularly now with COVID, it's a little harder to schedule procedures in a hospital. There's a limit on who can have those procedures right now. So uterine artery embolization is the procedure that we're kind of talking about today. And Vivian, is this a good time to talk about that?
It certainly is. That was my next question. What
Okay.
is the treatment?
So as an interventional radiologist, basically I am a body plumber where I access the blood system just like a highway and navigate through the body using X-ray guidance and go to wherever I need to go. And sometimes I'll open up arteries in the legs, like if a diabetic has a wound on their foot and I'm not opening, they don't have enough blood flow to heal it, well, I'll open it up. Other parts of the body, our goal is to maybe deliver chemotherapy to a liver tumor. In this case, we want to get into the arteries supplying the uterus and starve the uterus of its blood flow. So you get into the bloodstream. Most commonly, you would puncture the femoral artery in the groin, just like if you were going to have a coronary stent. We go in this artery. It's a very safe artery, but there's a newer technique where you can go through the wrist artery. It's called the radial artery. It's like the one they check in the movies all the time. So you can go through there. But anyway, you get in the highway, the bloodstream, you get into the pelvic arteries, and you get into the uterine arteries. And they're very, very typical appearing arteries. They have this windy mountain road look to them. And then you inject tiny little particles, these spheres, these inert spheres that are measured. So they look like teeny weeny eggs, but they're small, almost like the size of salt. And they flow into the branches of the uterus. You do it both sides. It has to be left and right. And you starve the uterus of blood flow. Now, the uterus is a very durable organ, and so it's kind of like the weeds in your backyard. If they go without water for a while, the weeds die, the grass lives. So the uterus lives, the fibroids die. Doesn't matter if you have one fibroid or 50 fibroids. That's one of the beauties of uterine fibroid embolization. You don't actually target individual fibroids. Like a myomectomy, you take out the biggest ones and you can't see the little ones. With a uterine embolization, I can't really see where all the fibroids are, but I can see the arteries to the uterus. And so all the fibroids die. And the cool thing about that is that if you're going to have a recurrence, it will occur 10 or 15 years down the road, because now the fibroids have to grow from one cell. They have to start again. Most women are going to have reached menopause by then. So traditionally, back when this was first developed in 1995, we were doing these in a hospital because that's where all the facilities were. But in 2004, I opened the first office suite in the United States, and now there's probably 800 office suites around the United States. And most of these are now done in an office setting. And we've developed very good ways to for pain control. And so a patient will come to the office in the morning, go home early afternoon, recover in their home with a friend or their mom or their sister, and they usually will start doing things around the house day 2 and day 3, and almost all the women will be back to work in about a week. Of course, you get to avoid the hospital where the COVID is.
Wow, that is amazing. Thank you so much. Do you have anything else you want to tell us about? If not, we can move on, and I really want to take a poll for our women, and really I want to ask if you have heard of a UFE before today. And the poll should be on your screen. And just like before, we'll give you a few seconds to answer, and then we'll see how knowledgeable our ladies on this Zoom were before today. But I know after today, we know a lot. Thank you so much for that information, Dr. Julian. And so
Pleasure.
More than half of the women on the call had not heard of a uterine fibroid embolization before today. There were 45% of us have, but you have educated more than half of the women on this call. And so we do have, I'd like to go to the chat for some questions.
So Vivian, I want to make just one comment about it's kind of alarming that this is not surprising. This is not insulting. This is what we see, is that a lot of people don't know about it. And if you have a minimally invasive procedure that's been around forever, like Condoleezza Rice got one of these, the former Secretary of State, in 2004. And so why don't they know about this? And it has a lot to do with healthcare in the United States. Most women with female problems go to their gynecologist, which makes sense. But the gynecologists don't do this procedure. They do their cutting procedures, the myomectomy, the hysterectomy, and they have a prejudice. Since they don't do it, they don't want to talk about it. And also there's in some, not all, but in some people, there's a financial drive to do it. So when you go to the butcher shop, the butcher's not going to tell you about the fish market down the street or the vegetable stand next door. He's going to say, yeah, well, you can, if you want tilapia, it's down the street. But if you want a nice filet mignon, you come here. And they're going to constantly promote their procedure. Now, there's been a lot of pressure, and I can even show you some slides. Even the ACOG, the American Academy of Obstetrics and Gynecology, they've put out position statements in 2008 that says every gynecologist needs to tell their patients about all possible treatment options, including fibroid embolization, which has level 1 data and is a very good procedure. And so it's interesting that we've been seeing more and more. I think they're more likely to refer, and especially during COVID, we've seen a lot more interested people. And when I talk to our OBGYNs and the patients, it has to do with the OBGYNs don't want to go to the hospital right now, and because of COVID, and they don't have OR time. And the women, they're not going on vacations. They're sitting at home. They're like, why don't I do these things that I've been wanting to do? And I've got this female problem. Let me get it taken care of. And so we've actually seen quite an increase in interest in this and a lot more knowledge. So I talked too long. Please ask your questions.
You know, you mentioned that Condoleezza Rice had her procedure in 2004. I had my myomectomy in 2005. And at that time, I did not know about UFE, and I wish I had. So thank you so much. So I'm going to go to the questions. We have one in the chat. So for women who haven't had children yet, will their cycle be light? Let me see. Will the cycle being light affect you long-term from having children? So for women who haven't had children yet, will your menstrual cycle being light affect you long-term from having children?
Perhaps that lady could say how old she is. So there's a lot of discussion about fertility. We don't generally perform this procedure for fertility, but what is an extremely common, she's 40, which is an extremely common question is the 40, 45-year-old woman will come in and either they've had kids or they haven't had kids, but they say, I want to be able to have kids. And now, I want you to listen carefully. This is what they tell their gynecologist. And I'm going to ask the question, what do you think most of the gynecologists say after the person, the woman tells their gynecologist that? Well, as shocking as it is, most of the time, they still recommend hysterectomy. So what is the likelihood of getting pregnant after hysterectomy? It's 0. Now, they say that because I guess it's just their favorite surgery. And so you have to look at your options. Anybody who's 40 has a much less likelihood of getting pregnant than a 20-year-old. Those are just the facts, with or without fibroids. And as you get fibroids, it's also less likely. So your option is really myomectomy, which if you're going to get pregnant at age 40 and you only have 1 or 2 and you're ready to get pregnant, that might be a good option. But if it's sort of a nebulous thing that maybe someday in the future, that's not a good option because they're going to come back. And if you have 2 myomectomies, which a lot of women end up having, it's extremely low likelihood you'll ever get pregnant because you scar the uterus when you have the surgeries, and it's hard to conceive. So if you don't know when you're going to have get pregnant, the uterine embolization may be a good idea. And the problem is there's not a lot of data out there. So this is the key answer. There's no one's ever compared the different treatments, myomectomy versus uterine embolization. You can only look at studies and you have fragmented data. What you can say is we have had a lot of women get pregnant and carry a baby to term after uterine embolization, even to the point that we tell women they should take birth control pills, because a lot of women who have the procedure are not on, I don't mean birth control pills, some kind of birth control. They're not on any birth control because they weren't getting pregnant. Maybe they wanted to get pregnant and years and years and years and years have gone by, and the fibroids may have kept them from getting pregnant. So if you have an embolization, those fibroids shrink. Now the egg can implant and it can go to term. You might get pregnant. And so early on in our experience, 20 years ago, there were some angry women who were like, well, why didn't you tell me I was going to get pregnant? And because we weren't really aware of that. So now when we counsel people, we'll say, if you don't want to get pregnant, you're not, and you need to be on some kind of birth control. And so we know a lot of people get pregnant and they go to term. We also, in some studies, there's a gentleman named Pisco from Spain who did some of the original uterine embolization studies. And in his very large series of the women who wanted to get pregnant, who had embolization, about 60% did. So I guess I'd say that it's very common. It's common that you can get pregnant. But it's a challenge also because this population of women is older, which makes it less likely they'll get pregnant, much more hard. And they've had fibroids, so there's going to be a distorted uterus. So I hope I answered that.
Yep, I think you did. We have some other questions. One attendee says, can you choose ultrasound instead of MRI to see and measure, and especially for cost? And I think you kind of went into that a little bit as well, but I wanted to.
Yeah, we really like to have the MRI if possible, and we haven't really had any problems with insurance companies. You know, that could be an issue, I suppose, if you're paying cash and it wasn't covered by an insurance company, but we haven't really had any issues. We just had a patient come the other day who supposedly had fibroids. So when we did an MRI, it turns out they didn't have any fibroids. They had a distorted uterus. It was lumpy from myomectomies, from cesarean sections. And so it was misread on the ultrasound. And there are things that could be missed. So you could do, and some people have done it, but I think there's more likely that you might miss something. And it's also nice to be able to compare your results. See, this is how big it was, and now 6 months later, this is what it looks like, and you can see if you got a good result.
You touched on this about insurance because someone did ask, is this covered by insurance?
The answer is yes. 15, 20 years ago, the insurance companies may try to say it's experimental, but they can't say that anymore. There is a massive amount of data. Some insurance companies exist to deny payments and try to avoid things. One insurance company in particular will come up with, they'll give you preliminary approval, you'll do it, and then they'll come up with excuses why they don't want to pay. So we've actually figured out what that is. And with these little hoops you want to jump through, they'll say you didn't get an endometrial biopsy. So now everybody gets an endometrial biopsy. They get a pap smear. You document how much bleeding they have, how much pain medication they're taking, and all these things. So you check off all the boxes so that the insurance companies the HMOs can't come up with an excuse of not to pay. So we've not had any problem in the last 5-6 years in getting insurance approvals and getting paid. And so all of the major insurance companies would cover it.
So someone said, why don't doctors tell us about this procedure? You kind of went into that big length, so I appreciate that.
They don't do it.
Yeah, right. Yeah. So one question, how long does this UFE take, and are we awake during this procedure? You kind of touched on it a little bit, but if you could go into that more, that would be great, Dr. Julian.
So, I have let me just see if I can show you a slide. Oops. Okay. I mean, the history of how this was developed is kind of interesting. So in 1995 in France, a surgeon who was doing myomectomies said, there's a lot of blood loss we're getting here. Maybe we can do an embolization before. So embolization is a procedure we do all over the body. Like if you're in a car wreck and you have bleeding from the pelvis, you might plug up little arteries in the pelvis. So, or if you're getting kidney surgery of a big kidney mass, you may plug the kidney artery so that when the surgeon goes in, they take out the kidney, you don't bleed as much. So in France, this surgeon had his interventional radiologist embolize the uterine arteries before the myomectomy surgery. And when all the patients started canceling their surgery because their symptoms went away. And that's when it was serendipitous. They hit on this idea and they says, hey, maybe we could use this as a treatment. And so that was actually kind of a nifty way that it was found. I wanted to put this is my crew here. This is my 3 mid-levels, and Anissa and Mana and Charlene. And we have our 34 employees. Here's our 3 offices. But if a woman calls to and is interested in scheduling a consult, let me just kind of walk you through the way it works, and then we'll talk about how long the procedure is. So we usually start with telemedicine. COVID has changed this, where we realize we can do a lot of things by telemed, just like we are in our call here. And they'll get all the history and information. If they need an MRI, they haven't had it yet, they'll order it. It'll come to the office, I'll review it, give the lady a call, we'll talk about it. And if it looks like she's a good candidate and wants to go ahead, they'll schedule a time. And then they come to an office for a formal physical exam, and they meet with our operating room nurses, who will in detail go over the procedure, and we'll go over the regimen of medications that we're going to use. So if the procedure is not painful at all, the worst part is the sting in the groin, like a blood draw, or the radial artery, wherever you go in. The painful part is the starving of the blood flow after the procedure is done. Now, if you didn't know that was going to happen, that would be kind of alarming, but guess what? We know exactly what's going to happen, and we're ready for it. And so we actually have medicated the patient beforehand, and we understand they might have like a flu-like syndrome afterwards. So we give them medication for that. They may be nauseated, they have medication for that. So they have a cocktail of medications that will get them through the first, through the whole recovery, the first day being the toughest, like Melissa said. And, but and we also we give them instructions. Their caregiver, who's going to be with them for the first day, is also educated. And then the day of the procedure, they come in, they get rolled into our procedure room, which is a fancy room that has, x-ray and ultrasound equipment. Procedure generally takes about anywhere from 30 to 90 minutes, depending on how easy it is to get into your uterine arteries. The discomfort would usually start when the procedure's over, and you go to recovery. And then about maybe 4 to 5 hours later, you go home. And so you're in the office, maybe 5 hours would be kind of a typical, and everybody's involved. We have a whole team here. It's kind of like a restaurant. Everybody has their role. And we've done hundreds and hundreds of these in our office interventional suite.
Wonderful. We have a question in the chat. If any women have fibroids which are not affecting them, shall they just leave it as is or get them removed?
So that's a very good question, and I should have brought that up. Nothing's wrong with having fibroids. If 80% of the women 50 have them, and then it's in the old days, your gynecologist would say, you have fibroids, we should remove it. That's like taking the tonsils out. That's like all these historical operations that didn't really need to be done. The surgery has risks and side effects and cost, and takes you away from work and family. There's no reason to do it if you don't have symptoms. These will involute at menopause. So it's extremely common to have no symptoms or minimal symptoms. And so just because, people have I used to wrestle, my shoulder hurts. I don't want a joint replacement. I'm going to live with it. There's lots of aches and pains and miscellaneous. So you have to kind of decide, how much is this bothering me? But you also have to keep in mind, in menopause, they will shrink up, and most women's symptoms will go down quite a bit.
And, someone here was listening to you and saying that you were so correct because she is at home suffering. So I know this information is important for her. And then our last question really is from someone who lives in Miami, and she wants to know, is there a location in Miami? Where are you located?
So we have 3 offices. one in Plantation, which is just west of Fort Lauderdale. We have the Coconut Creek office, which is on Hillsborough 441, just south of Boca Raton. And we have a Boynton office, which is just off the Turnpike and Boynton Beach Boulevard. And like I said, we can do telemed visits and minimize. We have people from out of state who come they'll come the day of the procedure and from out of state, because we can do most everything else by telemed. And there are places around the country. I'd have to there's probably places in Miami. I know there's places in Miami. Some of my proteges work in Miami as well. So I'd have to kind of, if they want to send us an email, then I can maybe give a recommendation, or we're happy to take care of you. I've been doing this for 28 years, and we probably have more experience than there's only a few people in the United States who have more experience than us, and opened the first office suite in, like I said, 2004, and it's become a popular thing to have now.
Well, like I said, I wish I had known you in 2005, Dr. Julian, because I would have definitely have gotten a UFE. So those are all the questions that I have and the ladies have. They have thanked you for answering. Oh, we've got one more. Are there any options for transportation after the procedure if there is no one available at the time to?
There needs to be someone available, because it's important for this. There's some procedures where you don't need anyone. You're not sedated. This is a procedure where we expect there to be discomfort and you're going to be groggy. So you really want to have someone with you, and you're going to go home and be groggy and need to have someone available. So most women who are 35 to 52 are going to have someone they can find. They're the most common being sister, mom, friend. Occasionally you have a responsible husband who will fulfill that role. But it's really important to have someone. We would not want to do this and send someone out on a van to go home and be groggy at home the first night. So that would be my answer.
And then one other question from attendees popped up. Can anything go wrong with this procedure? What are the risks?
So every procedure has risks. An aspirin medication has risks. Not treating has risks. And so it's kind of like everything in life has risks and benefits. If you get on an airplane, it's pretty safe, but there is a tiny risk you're going to crash. And you have to get comfortable with risks and benefits. And so fortunately, this is a very safe procedure. There's some small risks. There's a little risk of bleeding from your access site. There's a tiny risk that you'll pass a bigger piece of tissue. So some of those tumors that are in the inner lining, they can actually it doesn't happen right away. It could happen weeks or months down the road. You could actually pass those. That's not really a complication or a problem, but it is a problem if the tumor was big enough, the fibroid's big enough that it plugged the cervix. So if we think that might happen, we have a conversation with the patient and the OBGYN and we'll say, this fibroid could break off, and just be aware of it. You might have abdominal cramps, and the gynecologist may need to help pull the fibroid out through the cervical canal. That's happened. There's been some rare events where extremely rare, this is out of hundreds of thousands, where in the literature, so when there's something kind of an obscure complication, most doctors will never see it, but you read about it about someone in another country or whatever. So there's been some fibroids that have come off the uterus on the outside, one or two. There's something called non-target embolization. That would be the equivalent of hitting a bystander with your gun and not where you were shooting. So those are little particles that went to the wrong location. Those are also super uncommon. And it also has to do with the skill of your interventional doc. So you want someone who's fellowship trained, who's been doing this for years, who's got a good track record. It's not a commodity like, it's a specialized field that we have. We're essentially minimally invasive surgeons. And so you want to find someone with the best credentials who's got a good track record.
Thank you, Dr. Julian. And I will say to the lady who mentioned the transportation and asked about that, someone in our chat has said she can be a sister buddy for you. So just reach out. I've taken down both of your names, so I will make sure that South Florida Vascular Associates has that information just in case you go for more information.
A good Samaritan. That's very kind.
Yes. So one person says, my doctor told me that I am not a candidate for UFE because my fibroids are too large. Is that correct?
No. So we used to think maybe they could only be a certain size, but over time, there's been bigger ones done and bigger ones done and bigger ones done. And now the consensus is there's really no size limit. When even those ones bigger than we've treated ones bigger than the ones I've shown you. You don't have to get it to shrink. People think, well, if it's this big, it needs to really shrink down. That's not true. This procedure is 90% effective at eliminating symptoms of bleeding, or what we call bulk, pushing on things. 90% effective, and it doesn't have to shrivel to zero. Most of fibroid tumors shrivel to about half their size. So I think of it like a fruit, like an orange coming off a tree. If you came back a few months later and on the ground you saw an orange, you would know it's an orange. It would just be a gnarly, shriveled up one. That's what these do. You don't have to have, so there's no size limit. And the OBGYNs will frequently say there's a size. They'll say, oh, that's too big. You have a 3-month pregnancy sized fibroid. We need to remove this. And that's just simply not true. So you would be the type who should probably have a consultation. And I'll also say a lot of those people with the big fibroids don't even have symptoms, but the gynecologist may say you need to have that removed just because that's traditionally what they've done.
Right. Well, we want to change that, right? We want to change that. One other question: does it matter if the fibroid is inside or outside? And I think you showed some pictures that had both.
No.
So
There are some limitations that we look at on the MRI, and that will help guide what we do. But they can be in the inside, the middle, the outside. One of the things, if it's on the outside, if it's bulging way out, that's fine. If it's on a stalk, like a mushroom, that might be a problem. That would be one that we would be concerned could break off, and we would know that beforehand, and we would deal with that. The OBGYN could clip it, remove it, or maybe it's better done, treated a different way. But those are the kind of things that we would be looking at on the MRI.
another question has popped up. Does it matter? Oh, I'm sorry. Why do I have pain in my fibroids if I'm past menopause?
Well, you'd have to ask your gynecologist that. Most women don't have symptoms after menopause, or at least, they have to give it some time to shrink. And it could be from something else.
Someone's asked, how can this recording be shared to others? And we were live streaming on South Florida Vascular Associates page. So go to that page and direct them to that page. We have another question. Once removed, does the belly shrink?
Yes.
It's quick and simple. So woohoo, we all want our bellies to
It may not be as skinny as high school, but it'll shrink. 50% is the size that on the average, some more, some less.
Thank you. I think we have gotten to all of the questions. Again, you can get a consultation. I just want to thank you, Dr. Julian, for the information that you've shared with us. I want to thank you, ladies, for joining us. We hope this information has been helpful. It seems like it has from the questions in the chat. And we hope that you are looking forward to connecting with the South Florida Vascular Associates to discuss your situation and how you can improve and relieve your fibroid condition. You may call 954-725-4141 or go to the website www.sfva.com. You see it on your screen. You can set up an appointment for a consultation, and please be on the lookout for a quick follow-up survey, because we want to make sure that we get your feedback on how this went, so that we determine if we can have some other health talks. So I see one last question. If you can put that in really quickly, we will do that. Should you try the medical treatments before this option?
So you can try it. We talked about a little bit before about that. Usually they're temporary, and they will recur, and there's a lot of side effects from the medication. So that's something that the gynecologist will typically work with you on. And maybe it might help for a temporary rough zone you're going through, but a lot of women don't like the side effects, and they don't want to be on the medications long term. It's not a long-term solution in most cases.
All right. Is it normal to have large clots with each menstrual cycle?
The women should know what their typical cycles like. Some have heavier than others. And the more bleeding you have might be a problem. It's not uncommon that women will be on iron because they're anemic, and some women will be like my healthcare person we showed the MRI on had a life-threateningly low hemoglobin. She was bleeding to death and probably would have passed out before too long. So you definitely, if you're having all these big clots, you probably should have your blood checked, get a hemoglobin measurement. And but the gynecologist will help guide you on what is too much bleeding to be having.
Okay, I think we've answered everything. And if not, get in touch with Dr. Julian so that you can have a consultation and get even more questions answered. Thank you, Dr. Julian.
It's been a real pleasure. Thank you, Vivian. And also thanks to our patient who was nice enough to share part of her morning, Melissa. It was a pleasure to see her.
It was. She's a joy. I had a chance to talk to her earlier. Everybody appreciates the education of these options.
Good.
So that we are going to let you go back to your day. Again, don't forget, ladies, to please fill out the survey, and it has all of the information for you to get in touch with South Florida Vascular Associates. Have a blessed day, everyone.
Bye.